Okay, first I just want to thank everyone for showing up. It's late and I'm sure you're starving, and here I am, the third speaker at 7:30 at night, so really I appreciate you staying. I really feel grateful to be at NYU. It was a lure to come here, I have to say, from New York Hospital. I thought I was going to retire there when I trained there, but I've been at NYU for 18 years now, and there's such a camaraderie here of physicians, and I think with internet, even though we all have very busy lives with internet, we're able to connect on a regular basis. I see Dr. Schnabel every week in the OR. I share a locker with Dr. Axelrod, so even though I'm early in the morning, I'm tired, I open the door to our locker to change, and there's all these colorful clothes, and it's just a reminder that I get to work with really nice and fun people every day. So what I'm going to try to cover in about 3 minutes is some of the fertility issues that affect cancer patients. And so just starting out here, this is a graph of fertility in women by age. And I think most people, it's predominantly women in the audience, but most women know that fertility does decline with age. And actually our peak fertility is in the 20s and early 30s. Actually, the most rapid decline we see is beginning at 35, and by 45, virtually all women are infertile. Well, despite that, about a quarter of women have never been married by the age of 35, and about 1/5 of women who are 35 wait to begin having their families until that age. Well, if you overlay that with a 13% incidence of breast cancer in reproductive years, you're going to find that it's not a very good equation, so that many women, the ability to have children is jeopardized. So it's why our disciplines have come together. The other speakers tonight have really pointed out that there's been tremendous strides in both diagnosis and treatment of breast cancer, so that almost all cancers diagnosed now are either localized or regional. And if you look at the 5-year survival, which is in red, it really is heading toward that, not 100% mark, but in the at least 80s. So for women less than 45 years old, the overall survival rate is 81%, which is fantastic. But this comes with a cost. So as Dr. Orez pointed out, many women will receive chemotherapy as part of their cancer regimen. And chemotherapy is a drug that is put into the vein, and if something goes into your vein, it's going to go through your whole body and go through every cell. So what we see is chemotherapy here. We have a representation of an ovary, and when the chemotherapy goes through the ovary, many of the ovaries are washed with this chemotherapy and are destroyed. And so what we see is very accelerated atresia, meaning the ovary cells are dying. And this is what happens in nature. So when women go through menopause, they don't just run out of eggs. It's not like you have 10 left at 50 and the next day you have none left. There's just this relative atresia going on month after month, particularly after the age of 35. And the chemotherapy really accelerates this process. Well, this is mapped out in 1999, looking at the effects of chemotherapy or chemotherapy plus tamoxifen, and the effects and the chance of menopause in 1 year after treatment. If you look at the circle line at the bottom, that's your natural menopause curve. And if you look 2 lines up, you see that's chemotherapy plus hormone therapy. And you see the greatest rise is in women who are 35. And the important thing about this data is this is looking at the chance of menopause. What we aren't able to detect in a lot of women is before menopause, really more than 10 years before menopause, women become less fertile. About 15 years before menopause, women are less fertile, and it's really hard to tell when women are less fertile because they're still having periods and they still feel fine and they're exercising and they look good, but oftentimes the ovaries are really quite compromised. And so at the age of 36, about 20% of women will experience menopause, and probably many more will have decreased ovarian reserve or a bad effect to their ovaries from their treatment. The culprits, the biggest culprit is cyclophosphamide or Cytoxan, which is an alkylating agent, the same one that is notorious for removing the hair on your head in probably a weekend. I'm going to switch gears a little bit and talk about hormone effects in breast cancer patients, because a lot of what I do deals with administering hormones or measuring hormones in women. And so a big hormone problem is pregnancy, right? So we know that breast cancer and estrogen are related. Dr. Oratz and Dr. Schnabel just pointed that out. And so lots of people are looking at pregnancy and how it affects breast cancer prognosis. And it's kind of an irony because women who have more children and have them early have less breast cancer, but breast cancer is such a high estrogen state. And so when you look through the literature, there are quite a few studies looking at pregnancy, and many of them show that there's no adverse effect. Some show that there's even a decreased risk in pregnant women, but it's a scary situation when a woman's had cancer and then she wants to get pregnant and have this high estrogen state in her body. And I leave that to the breast surgeons to really talk to the patients. Another big hormone issue is hormone replacement therapy. So when I was training as a resident and as an early attending, we really told everyone to take hormone replacement. Women who go through menopause, me included, know that it definitely isn't one of the highlights of life. And women show up and they want the cure. They want the cure for menopause. Just like breast cancer, they want the cure. Well, so one large trial that was carried out, the WHI trial, was a hormone replacement trial. And unfortunately, as they were doing the trial, they had to discontinue it prematurely after 5.5 years because what they found is that there was a higher incidence of breast cancer and there was a little bit higher incidence of stroke in the women. And the study was discontinued. And basically all doctors stopped prescribing hormone replacement for women. And what we saw is in the next year, there was a 7% drop in breast cancer. And this was reported in the literature. And basically, if I were a hormone therapy doctor just replacing hormone replacement for menopause, I would have had to close my office because really we just stopped prescribing it. It's now actually the pendulum is swinging back again a little bit, and I don't want to get too deep into that, but there are people who are now advocating using estrogen, but not in the setting of breast cancer. Looking at fertility drugs, so that's another hormone state where we're actually giving hormones that will raise the estrogen hormone inside a woman. So we're not actually giving them estrogen, we're giving them something that raises estrogen in their body. And if you look at fertility treatments that have been given to women and the incidence of breast cancer, this is one of the large trials that came out in 2003. They said if you had ever used fertility treatment, like they asked women, well, if you used anything, was there an increased risk? And the answer was no. If you look at the odds ratio, it's 1, which means it's no different whether you took it or not. But when you looked at HMG, which is a fertility drug that we use, it's a hormone, women who had ductal cancer had a 1.6 odds ratio for developing breast cancers. And really what this study, when you really read the nitty-gritty of the study, what they said is that they don't think that fertility drugs are associated with an increased risk of breast cancer, but women who had used at least 6 courses of the treatment may be at increased risk. Well, around that same time, multiple other studies were being carried out around the world. In Israel, a big trial came out that said they couldn't confirm any increased risk. In Italy, a trial said there was an absence of association with breast cancer. And last, in France, a pretty large study came out saying, again, there was no influence in breast cancer. So in general, we do not counsel patients that fertility treatment increases the risk of breast cancer. But I think the important thing is that when we use fertility preservation treatment, we're talking about using 1 or 2 treatments at most, so about 20 days of treatment all in, and we do not feel that has an increased risk for breast cancer. So why is fertility preservation important for cancer patients? Well, females with cancer are definitely living substantially longer lives. Survivorship issues are now very important to women. It's not just you're cured, thank you, goodbye. Quality of life issues are really coming into play much more than even a decade ago. And it's clear that women of reproductive age clearly want to maintain their biologic fertility if it's possible. In 2006, ASCO, which is the largest cancer society in America, it has 28,000 members, so it reaches out to a lot of cancer physicians in a lot of different disciplines, put out this sort of a statement paper with some backup data saying that actually fertility preservation is important, if not necessary, when counseling patients, when they're having their cancer treatment planned, that they need to be aware that some of the treatments might cause infertility, and you know, they should be given the chance to deal with that if they so please. Who are the candidates for fertility preservation? This is the cancer incidence in blue and cancer mortality in red of the top cancers that affect women, and you see breast, unfortunately, is the forerunner with almost 200,000 cases diagnosed in 2010, and thankfully the mortality bar is much shorter than that. All in, there are about 700,000 cases of cancer a year, and 10% are in reproductive age women, and about 13% of them are in breast cancer. So this is a big group of women that I now take care of because there's a lot of women in New York. So why do we need fertility preservation? Well, as the other doctors have already pointed out, there's increased survival and you know, better detection, better survival. But the thing that a lot of people aren't paying attention to is that women are waiting to have children. I'm surprised Mr. Romney and Mr. Obama haven't discussed this at all, because I really think it's going to impact our society that women are waiting so long to have children. In fact, if you look at the census data for America, the only birth rate rise in America is in women 35 to 39 and 40 to 44, and it's the highest it's been since 1969. And the overall birth rate for women is as low as the Great Depression right now. So it really is going to change societies. In some of the smaller countries, they're already feeling it, but I think we're going to see a big change in America as well. If you look at the age of first birth around the world, the United States is at about 25, not bad when the mean in the world is about 27. If you look at the European countries, it's much higher than here. So this isn't a New York City phenomenon or Boston phenomenon. This is worldwide that women are waiting to have children. And what that translates to is that there will be more women who haven't completed their childbearing when they are diagnosed with a cancer. And that's really what's brought our disciplines together. On top of that is diminished ovarian reserve. So just in nature, women are born with about 1/6 the eggs they started with. So in utero, a woman has about 6 to 7 million eggs. And by birth, she's down to about 1 million eggs. And that's kind of a dirty trick when you think about evolution and biology and why things happen. I just don't know why. I don't know why we lose all those eggs before we even come out of the blocks. And then, you know, you can't have a child before puberty, and at puberty you're down to 15% of the eggs you would have started with. So you're down to 300,000 eggs. And by 30, things are still okay. So from 15 to 30, you're doing okay. But from 30 to 40, you go from 240,000 eggs to 60,000 eggs. And this is why there's so much fertility between 30 and 40. The fertile time is really from 15 to, the most fertile time is really from 15 to 28. And that's not when the women are being diagnosed with breast cancer after 28 most of the time. So that leaves us with more cancer diagnosis and survival, women with no or a low number of children, and women with a fertility desire, or they might be unsure. At 30, you might be unsure whether you want to have children or not. So what are the fertility preservation methods we use for women who come to the office with breast cancer and are interested in preserving their fertility? We use both embryo and egg freezing. And I just briefly wanted to go over, I don't know if people are interested in this, but just briefly how this all works. And that is that we give gonadotropins, or basically a hormone, to stimulate the ovaries. So normally the ovary would just make one follicle, and we make the ovaries have multiple follicles. And when the eggs are ready, we actually harvest them out. It's about a 2-week course. And when we take them out, we either freeze them that day as eggs, or we freeze them the following day after having them with sperm overnight so that fertilization can occur. So embryo freezing became the standard of care for fertility preservation early on. When you look at the results of embryo freezing, if you look at the fresh IVF, meaning people who are going through in vitro fertilization by age, you see the blue curve, it's about 35 to 40% of women get pregnant overall. Well, that's the same with frozen embryo transfer. So it's about 1/3 of women get pregnant with frozen embryos. So it's not 100% treatment. And I think sometimes egg freezing is getting a bad rap, and embryo freezing is just this, standing alone on a pillar. And really, things aren't 100%. It's about 1 in 3. There have been a lot of births from embryo freezing, about 250,000 births. But if a woman doesn't have a partner, it requires the use of donor sperm, and that can be a deal breaker for a lot of women who show up. Why egg freezing wasn't the original standard of care? Well, even though the first birth was 26 years ago, their early results were pretty dismal. Couldn't reproduce the techniques, low fertilization, low pregnancy rates. And the reason for that is the egg is a very large structure. In fact, it's one of the largest structures in the body. Other than the neuron, the nerve with its long axon, it's the largest structure in the body. And it's 80% water, so it's hard to freeze something that's 80% water. You think about a lake, freezing with water and the cracks that happen, or you think, I have a son actually who's 12, and he'll go to Duane Reade after school. I don't buy soda, but he does, and but he has to drink it before I get home, so he'll put it in the freezer, and then he forgets that he puts it in the freezer, and then I open the freezer the next day, and there's the orange soda. So we know what happens with water is that it expands, and when something expands and is as delicate as an egg with all its internal structures, it wreaks havoc. Well, just in a nutshell, that there have been major technological advances that have moved egg freezing into mainstream fertility preservation treatment, and so now it's a very viable option for women. Some of the great work that's been done in egg freezing was done in Valencia, Spain. They actually petitioned their government and got their government to sponsor a study comparing using fresh eggs and frozen eggs, and they were able to show that they have the same number of embryos implanting and the same pregnancy rate using frozen or fresh eggs. At NYU, we have in non-cancer patients, so women come both for cancer and non-cancer to freeze their eggs. In non-cancer patients, we have a very nice pregnancy rate. This isn't so important to you, but obviously with age, we see a lower pregnancy rate. We've had 11 women who froze their eggs between 40 and 42 come back, and 1 has successfully delivered a baby. She just delivered in August and sent this picture. But in general, the clinical pregnancy rate has been 56% and about 44% for women delivering babies. So in fact, that might sound low to you, but from a fertility treatment, this is a very viable option. In 2008, looking around to see how many babies there were, people were saying maybe 100, 200, but in fact in 2008 I was able to cull together 936 births from literature around the world and show that there was no increase in birth anomalies. And this publication actually became important because the whole issue about new technologies is safety, and safety in fertility is healthy babies. So getting information out about healthy babies was really important. So much so that yesterday, our governing body, the ASRM, the American Society of Reproductive Medicine, released their guidelines, finally removing the experimental label from this technology. And the important thing about that is when a technology has an experimental label, patients can't get it covered by insurance. And so taking this experimental label off is going to really help to get the insurance companies to cover fertility preservation for cancer. Just in looking at the patients that have come to us for oocyte cryopreservation, we've done over 1,000 cycles at this point. About 20% of them have been medical. Looking at the cancer patients, if you look, breast is in red, gynecologic cancers are in blue, hematologic cancers in green, meaning the lymphomas and leukemias. Really, breast is the front runner because the diagnosis is so prevalent. We see more breast cancers than it actually has surpassed the GYN patients now. Interesting, just looking at the data, about 50% of the patients who come are partnered, meaning they have, my definition of partner is in a committed relationship for 1 year. If you just use marriage in New York, you're gonna have a really low number. So it's not common law like Vermont where 7 years, it's like 1 year in a committed relationship is good enough to me to call you partnered. About half the patients are partnered. And what's interesting is when I look back at those patients, 83% of patients chose to freeze at least some of their eggs unfertilized, which tells you that women really want reproductive autonomy. So they might have a partner, they might not have a partner, but if they're freezing something, they want the opportunity to choose who's going to be the sperm source in the embryo that's created from those eggs. It takes about 17 days from when I see the patient to when they can get back to their oncologist. So that's really important. Sometimes the doctors send the patients and they don't have 17 days. Sometimes they're too sick. And on average, we get about 14 eggs per patient. I looked at what happened with the cycles by cancer type. And if you look, breast cancer is in red. The cancer patients are the oldest patients we see, on average about 35 years old. The breast cancer patients are the most partnered, meaning more of them show up with a partner than, say, a hematologic malignancy, a lymphoma or leukemia patient who's 15 or 20 when they present. They have the lowest estrogen response, but we do that purposefully, meaning we give them a drug to keep the estrogen low so that we don't increase any risk of hormone sensitivity. But if you look at the breast cancer patients, they have a very reasonable number of eggs retrieved each time they go through. When we looked at, we use our non-cancer patient information to counsel our cancer patients. So it's really, I tell them it's like women helping women, because there's many more women in New York who are freezing their eggs for non-cancer reasons than for cancer reasons. But on average, we see about 10, 12, 15 eggs retrieved based on the age, and that helps me to tell the patient how many eggs they'll get. And when we compared that to patients who had frozen for cancer, we did not see a difference when we age controlled them. This slide is busy, but this is the patients who have come back. So of the 124 patients who came and froze for cancer, 9 women have come back. 2 of them were breast cancer patients. Interestingly, if you see, there are women who froze eggs and women who froze embryos, and most of the women froze either just eggs or they froze some embryos as well. What I found is that the patients who came back were the partnered patients when they came. So only one woman, one breast cancer patient, has come back and used donor sperm and had a child by herself. All the other patients who have come back actually came to me with their partner and then came back when they were well enough to be a parent. I circled the gestational carrier because of 9 patients who have come back, 3 required a gestational carrier. They were patients who had GYN malignancies and needed their uterus removed. But I circle that because a lot of breast cancer patients are advised not to get pregnant after their cancer. And so it's really important for me to remember to address third-party reproduction, meaning someone else carrying the pregnancy. Of women who used a carrier, 2 have gotten pregnant. One of the breast cancer patients is actually the oldest woman in the world who froze eggs from cancer and has delivered a baby. So froze eggs, had her treatment, came back, and has a baby. And she's brought that baby in. I've seen him multiple times. He's really terrific. And she's so happy. And I just remember when she came back after finishing her treatment and said, I've licked this thing, and now I'm going to have a child. I don't care if I have a husband. I'm going to have a child. The other breast cancer patient came yesterday, so she just came back to use her eggs, and she came yesterday and had a heartbeat, so that's really exciting. So as you said, Dr. Schnabel, for statistics, we're 2 for 2, so we're 100% on breast cancer patients. In treating patients, just in closing, in treating women who have cancer, it's a very different group than patients who are coming to me who are just infertile and either coming alone or same-sex or with a partner. The unique challenge is that these patients have just been told that they have, excuse me, a potentially life-threatening diagnosis. And I think what that does is take a tumor that's about 3 millimeter and expand it to the size of the room. And so they're sitting in the room with me and their giant breast cancer, and I'm trying to tell them about fertility, and I don't think they hear a word I say. When I asked the patient yesterday who came in, I said, do you remember me telling you about fertility? She said, no, I just remember that I had really good doctors here at NYU, and I trusted you, and I just did what you told me. So I have to keep that in mind also. I think I just have to remember to answer all the questions, like the third-party reproduction, how long the eggs can be frozen, if you don't make it, what happens to them. And I guess I don't really need to talk about this so much, but really age, it's really for postmenarchal, meaning women who have had their period. Up to age 35 is ideal, and I think it's appropriate up to age 41. And in conclusion, I think it's really important to point out that cancer cure is no longer defined simply by eradicating the disease, but now includes addressing quality of life issues such as parenthood after cancer. And of all fertility preservation options offered, embryo and egg freezing currently have the widest application and the greatest chance for success with breast cancer. And egg freezing has the added benefit, obviously, of reproductive autonomy, and that third-party reproduction needs to be addressed. And in conclusion, really the primary goals to keep in mind is that cure is number 1, 2, 3, 4, and 5, but adding the potential to have children when well enough and ready and capable is important when I'm counseling patients. And that's it. Thank you.